Clinical features of rheumatic fever. The criteria for diagnosis of rheumatic fever was established by Dr. T. Duckett Jones. As per the modified Jones criteria, the diagnosis of acute rheumatic fever requires the existence of two major criteria or one major and two minor, plus a history of a streptococcal throat infection. The major criteria include carditis, arthritis, that is monoarthritis, or migratory polyarthritis, Sydenham's chorea, subcutaneous nodules, and erythema marginatum. The minor criteria include arthralgia, fever, first-degree heart block, and elevated inflammatory markers, such as ESR and CRP. Evidence of streptococcal infection is an essential criteria that must be established before diagnosis. Evidence of recent group A streptococcus infection can be established by a positive throat swab, positive rapid streptococcal antigen test, raised streptococcal antibody titer, ASO or DNA-ASB titers, or a recent episode of scarlet fever. Carditis. All three layers of the heart are inflamed in pancarditis, seen in 50 to 60% of patients. It develops within the first 2 weeks of rheumatic fever. On auscultation, a pericardial rub is heard, there is a soft S1, presence of S3, and Carey-Coombs murmur is heard in congestive cardiac failure. Damage to the endocardium causes endocarditis and valvular dysfunction. The most common valve affected in rheumatic fever is the mitral valve. In rheumatic fever, valve incompetence, that is regurgitation, is more likely to develop than valve stenosis. Myocarditis results in heart failure and conduction defects. Arthritis. Migrating polyarthritis is seen in 60 to 75% patients. It is a flitting and fleeting type of polyarthritis involving large joints with no residual deformity. The joints become red, hot, and swollen. Individually, each joint is usually affected for less than a week. It occurs in early stages, like carditis. Jacquet's arthritis is ulnar deviation of fourth and fifth finger, with flexion at metacarpophalangeal joints. It is the only residual deformity seen in rheumatic polyarthritis. Sydenham's chorea, or St. Vitus dance. It is characterized by rapid, involuntary, and semi-purposeful, non-repetitive movements, more common in females. Sydenham's chorea is present in 2 to 30% of the patients. It is a rare and late-presenting sign of rheumatic fever, appearing around 2 to 6 months after the initial streptococcal infection. Occasionally the chorea is preceded by emotional lability or behavior, which is out of character for the patient. Subcutaneous nodules are hard, mobile, pea-sized nodules, typically found on the extensor surfaces, for example back of the elbows or the spine. They are often painless and normally disappear within 1 month. Seen in 3 to 5% of patients, they occur 3 to 6 weeks after onset of rheumatic fever. Patients who have subcutaneous nodules almost always have carditis. Erythema marginatum comprises macular lesions with an erythematous rim and central clearing in a bathing suit distribution, predominantly affecting the trunk and limbs, while sparing the face. It is described as a geographical rash because its borderlines resemble those drawn on a map. They are seen in less than 5% of patients and occur early in rheumatic fever. The minor criteria comprise fever, arthralgias, raised inflammatory markers, such as ESR and CRP, along with prolonged PR interval, as seen in first-degree heart blocks, and recent streptococcal infection. Further investigations and management of rheumatic fever are discussed in a different video. To get more such high-yield medical content, don't forget to subscribe. BasidiaMED. The easiest and fastest way to take advanced clinical history.